Hi, this is Larry Bauer, Chief Executive Officer of the Family Medicine Education Consortium, and I'm very pleased today to be talking with Dr. Robert Nielsen, a family physician who's Medical Director of the Pinnacle Health Medical Group in the Harrisburg, Pennsylvania area. Dr. Nielsen, thanks so much for joining with us today.
My pleasure, Larry. It's great to have an opportunity to share with you a little bit about some of the things that are going on here at Pinnacle Health Medical Group and some of the ways we're beginning to transition care from our traditional fee-for-service model to a more value-based contracting. I've had the opportunity to be in private practice for about 38 years and joined Pinnacle 2 years ago and have served as the medical director for about a year now. And we're taking many of the lessons learned in our own practice and how we develop team-based care and try to apply them to much larger organization.
So, Dr. Nielsen, could you give us some examples of the projects that you've taken on and what results you've experienced?
I sure can, Larry. We took our practice in Annville, Pennsylvania, which at that time has about 12 or 13 providers, and we started to take the traditional fee-for-service, heroic physician model and developed out by embedding in a private practice care managers, diabetic educators, health coaches. We've co-located behavioral health specialists within the office and begun to utilize them as adjuncts to care and a way for us to have warm handoffs in the office and to provide our patients with an experience that's a little bit different, an experience that maybe is much more focused on their own care, focused on what their needs are. When you have many different team members involved in the care, you have the opportunity to get a different perspective on the patient's care. We've had patients who would never share parts of their story with the provider because they'd be embarrassed or not feel comfortable that they do with others. And it really gives us a very balanced picture on how we become a truly patient-centered medical home and deliver care at an individual basis and improve outcomes and our quality numbers, and at the same time do that in a marketplace that it was financially viable to make those changes. We know that as we get to value-based contracting, we're going to need that team base of care to really change the spending and quality curve. And the big question has been, can we work on that in a fee-for-service model and develop that type of an infrastructure so that when it's time to do the appropriate risk contracting, we have the people in place, we have the experience, we have a knowledge base of what tends to work and what doesn't, and we can apply that on a much broader basis.
So you told me one of the crises right now facing your community, as in every community in the country, is what I would call the opioid crisis, the how to take care of people appropriately with the use of opioids. And could you tell us some about how this team-based care has helped you to address that issue?
I sure can, Larry. It's an area that we're very proud of and continue to work on. We had, through our electronic records systems, which at the time were 3 different electronic record systems. We now have the pleasure over the last 5 months to have been centralized into one system, healthcare system-wide record. But we began to identify patterns of utilization of opioids that raised concerns. Inside our medical group and our central office, we have a full-time PharmD. We have a director of quality operations. We have hired a patient experience nurse that works a lot with communication, and an outreach nurse who's worked in the behavioral health addiction sphere before. So we started with an educational program for our providers. We looked at dispensing patterns. We made them aware of what those dispensing patterns were and how they fit into the group norm as a whole. We brought in speakers who spoke about pain management philosophies, dosing, ways of weaning providers, rather weaning patients off of medications. We've discussed, we had DE agents come in to speak to the group about what was going on in the community, what was going on in the region, what were the patterns of diversion that we were seeing. We offered patients a perspective, an educational perspective, both in the written and media. We've been on television a great deal. We've done a lot of social media outreach. And over this process, we have been able to significantly reduce over the last 2 years our prescribing, where at the time we started, we were covered about 120,000 covered lives. We're now up over 200,000 covered lives. And we've reduced our prescribing pattern from over 24,000 prescriptions to 6,000 prescriptions over a 3-month period. Tremendous reduction, and when you look at the growth of the practice, we've been able to reduce the prescribing by about 80 to 85%. We've done it with the ability to help patients receive assistance if they wanted counseling. We've unfortunately found that patients who have been diverting. But all in all, it's been an incredibly successful program. We've been able to take our health IT infrastructure, we've been able to take our centralized pharmacological input and put together a program that has been very, very successful at the practice level as well as at the system level.
So could you speak to it there's a certain subset of patients who truly have just god-awful pain, and opioids are appropriate part of their treatment. And then there's other people who have pain where other modalities can be helpful. Can you talk about how that team-based care addresses those different subpopulations?
Yeah, sure can, Larry. I think the setting expectations for treatment and communicating those expectations so the patient understands what we can expect. Many of us who have been in practice during the 90s and early 2000s came to think of chronic pain as a fifth vital sign, what that meant. And we've begun to realize that even in patients who have significant chronic pain for medical reasons, narcotics may only be effective in 30 to 40% of people. So setting those expectations, setting those goals, having a team who can do outreach in between the visits so that patients have the opportunity to discuss their successes and their concerns. And again, when you have team members involved, stories get told that may not be told in the side of the traditional 10 or 15-minute office visit. Care managers come back with stories that raise suspicions. Perhaps family members are interviewed. So again, the team-based care is really puts forward to the patient the concern, helps us set and manage expectations, helps us produce with motivational interviewing, and serves as an additional resource for information from the patient. And very, very beneficial. You get a much more complete picture of the patient. It helps us not to stereotype patients, which is very beneficial to us.
So one other area that you've told me about is your work with congestive heart failure. Could you speak to that project and how that worked out?
I can. Larry, we've begun to work with registries. Our new electronic record system is great at giving us registry information. And one of those areas that we've begun to work with is congestive heart failure. The Pinnacle Health System and the Pinnacle Health Cardiovascular Institute has had a very, very robust inpatient and specialty-focused CHF program that has been successful with reducing readmissions for CHF and helping patients gather the support they need to self-manage. So a couple things have been done, and then I'll talk about one area that we want to work at even a little bit greater. When we look at those patients who leave the hospital who are followed in our congestive heart failure clinic, we find the readmission rates drop down to a 3 to 4% area for 30 days for an extended period of time. So we began to look at the data off our computer system and do some geo-mapping to look at where are the readmissions coming from and what are the likely causes as we explore those types of small pockets of patients. And we isolated maybe 3 or 4 small, well-defined areas where a lot of our CHF readmissions were coming from. And we began to explore some of the social determinants of these folks' care, and began to realize that, number one, they were located in areas where we didn't have clinics, or congestive heart clinics anyways. We also, we started to talk to patients about what adherence meant and where were the barriers to the care, and began to realize, because we have an incredible community health outreach program that's run through the hospital, and we also have a paramedic-based program. And we began to utilize those two services, our congregational health program and our paramedics program, to start to intervene and go out and see patients in between time. We used our congregational health program to get out to the community and check blood pressures, make sure that people who needed scales had them, and we're able to begin to mobilize community resources to make a difference in these patients' lives and allow them to stay home more successfully. We use care navigation in between. Our nurses do a lot of outreaches. There's a lot of phone calls that come back in. Now our challenge is, how do we begin to bridge that down to the next level, which is the type of congestive heart failure patient that I might see in my office who maybe hasn't had an admission, but certainly could benefit from this type of care management. So we're now on a single platform EHR, and we're beginning to look at how we link up the really great things that are being done through our Cardiovascular Institute, and then evolve those so that the patients in our primary care setting can begin to be benefited by those programs. How do I identify them? What are the pieces of the program that become important? How we engage them over a continuum of time to help them achieve better outcomes and a greater degree of health.
That's fantastic. So, Dr. Nielsen, we have just a little bit of time left. I'm wondering if you want to make any comments, your perspective. You've been a physician leader. You've built a pretty good-sized practice prior to moving into, that you maintained for many years in Annville, Pennsylvania, prior to moving into Pinnacle Health. What's your perspective on the challenges for a system like yours as you move towards the value-based payment modality?
Yeah, Larry, I think it's interesting. I think there's an interesting set of energies at play. You know, when you believe in relationship-based healthcare, and I think that's the key to improving healthcare, you have to have patient access. How do you expand patient access so that individuals can get to the right level of care at the right time with the right amount of care being delivered? From a health systems perspective, how do you expand the footprint? How do you make sure that the patient who has a need doesn't have to sit 8 hours in the waiting room with a sore throat? So we have we have one side, that pressure and that tension to expand access, expand hours, be more available. And then on the other side, you have the dilemma of needing to look at ways of what is the physician and provider capacity you have within the health system. So if we expand access and we grow and we make it easier for patients to be seen, what capacity does the system have to deliver that care? You know, we read so much about physician burnout, and I think if we don't pay attention to the capacity limitations, that's gonna fuel physician burnout. So the approach we've taken is, how do we modify how we deliver care? How do we make it more patient-centric, make it less provider-centric, and at the same time let the patient know there is a provider at the center of their care? What are the transitions that includes the care management nurses? What are the transitions that includes what the RNs do in the office, the health coaches, and how does that data feed back to the provider? I think the only way we can reasonably and economically afford improving access is to make differences in the model in which we deliver care. And that's an exciting challenge to face at this point in my career. Hopefully I can add some wisdom from all my gray hair. But I think it's really it's a neat challenge, and if successful, we'll have true value-based care.
Dr. Nielsen, thank you so much for spending this time with us. I'd love in a future podcast to pick up on this issue, because the issue of physician burnout and redesign of care delivery systems so they work better for the patients and for the whether it's the physicians, the nurses, the rest of the staff, is something that I think folks would really like to hear more about. I'm wondering if you'd like to mention your email address, just in case somebody wants to contact you. If they
First,
hear
Larry,
this
I
podcast.
welcome the opportunity to do that at a future time. And my email is rnielsen, and that's Nielsen, at pinnaclehealth.org.
Great, Dr. Nielsen. Thanks so much for joining with us today, and I look forward to future conversations.
Thank you, Larry.